Welcome, everybody. Good morning, good afternoon, depending on where you are. My name is Laura Tollen, and I'm a senior editor at Health Affairs and also the director of the Health Affairs Council on Healthcare Spending and Value. Thank you so much for joining us today for the latest in our series of Lunch and Learn discussions. Today, we're going to be focusing on the ideas and proposals that are described in a policy insight paper that is in the January issue of Health Affairs. The title is How Price Regulation is Needed to Advance Market Competition. And the authors are Robert Berenson and Robert Murray, who we are very pleased to have with us today. The name of our session today is What Can Be Achieved with Healthcare Price Regulation. And I wanted to just spend a minute on that title before we get into the meat of the webinar today. We had initially titled this session, Is It Time for Healthcare Price Regulation? But realized that that didn't really quite fit because the goal of this session is not in particular to rehash a classic debate between regulatory versus market-based solutions. Not that that's not a valid debate, but it's not the one that we're here to have today, and it may be one that would require some participants who are not here. But today what we're doing instead is starting from the premise put forward in the article by Bob Berenson and Bob Murray, that healthcare markets don't work well currently to ensure that prices are consistent signals of the relative value of goods and services, and that regulation and market-based solutions are not an either-or proposition. The important questions then become, how might markets function better with price regulation, and how could that be done most effectively? So that's where we're going to be spending our time today. The authors put forth a very thought-provoking thesis that regulation of healthcare prices, and particularly hospital prices, can bring market forces to bear on non-price factors that have traditionally been resistant to market-based fixes. And those factors are things like quality, consumer experience, and incentives for efficiency. So as far as how today is going to work, we will first hear from Bob Berenson and Bob Murray with some key points from their paper. And then we're going to bring in some additional perspectives from our two other guest experts, Miriam Logason and Mike Chernew. After some conversation amongst the panelists, we'll be able to take a couple, hopefully quite a few questions from the audience, and I'll get to that in a minute. So a couple logistical notes here before we get started. You can see on the slide that we just put up, I've listed a couple of papers that are very relevant to today's discussion. So two of them are from Health Affairs, one of them is not, that's okay. The paper that Bob and Bob are going to be talking about, a related paper by Miriam, and also one from Mike and his colleagues for the Hamilton Project. So, and I believe my colleague Sarah has also dropped that into the chat, so you can copy those down. I think we could take, well, I can leave that up for a minute, but just a couple other logistics. We encourage you to submit questions at any time throughout the conversation. Those go into the Q&A. The chat is not enabled. And then again, my colleague Sarah, who is a special assistant to the editor-in-chief, will be joining us. She's actually here now, but she'll join us on camera in a bit. And she'll be going through the Q&A and sharing your questions with us. And we'll try to get to as many of those as time allows. And as I said, I do encourage you to submit those really at any point in the conversation. There will be, the last third of the webinar will really be for Q&A, but if questions come up before that, please go ahead and submit them. I think we can take that slide down. Okay, so that's logistics. Let me now get to our introductions. We're really, really lucky today to have just an amazing quartet of experts on healthcare payment and prices. So without further ado, I'm going to start by introducing Bob Berenson. Bob is a board certified internist and an institute fellow with the Urban Institute, where his work focuses on, among many other things, Medicare payment policy, pricing power in commercial insurance markets, and new forms of healthcare delivery based on reinvigorated primary care practice. He is a former member and vice chair of the Medicare Payment Advisory Commission, or MedPAC, and has held senior positions in 2 administrations, including at CMS and in the Carter White House. He was also an initial member of the Physician-Focused Payment Model Technical Advisory Committee created under MACRA in 2015. So quite a bit of experience in payment. Next, we will hear from Bob Murray, Bob Berenson's co-author on the paper that we're going to be talking about. Bob Murray is president of Global Health Payment LLC, a management consulting firm specializing in incentive-based payment systems for hospitals. Prior to consulting work, Bob was executive director of Maryland's all-payer hospital rate setting system for 17 years. And among other things, while he was there, worked on a prototype of the state's current hospital global budget program, which we'll hear about. He's also worked as a consultant on payment innovation for the states of Vermont, Oregon, and Rhode Island, and internationally for China and the World Bank. We then will be joined by Miriam Logason. Miriam is a political scientist and health services researcher and associate professor in the Department of Health Policy and Management at Columbia's Mailman School of Public Health. She's published widely on physician payment policies and the process used to determine Medicare fees. Her 2016 book, Fixing Medical Prices, influenced state and national policies, including informing recent National Academy of Medicine reports on primary care and nursing. She also co-authored a November 2020 paper in Health Affairs, which was on the slide that I showed previously, on physician payment policies in France, Germany, and Japan, along with Michael Guzmano, Victor Rodwin, and Larry Brown, and is currently working with those same authors on a book on that topic. And of course, she'll be sharing some of her perspectives from those countries as it's relevant to the conversation today. Last but not least, we have with us Mike Chernew. Mike is an economist and the Leonard D. Schaeffer Professor of Healthcare Policy at Harvard Medical School and directs the Healthcare Markets and Regulation Lab there. Mike also is currently on MedPAC and in fact is currently the chair of MedPAC. He has served on technical advisory panels for CMS, focusing on the assumptions used by the Medicare actuaries to assess the financial status of the Medicare Trust Fund. And I think with that, all of our speakers have many other accomplishments and publications, and we're just so pleased to have you all here. And I think with that, I'm going to turn it over. Bob Berenson is going to start first. Bob will talk us through some of the main points in their piece, and then we'll have some conversation. So thank you. Welcome, Bob. And Bob. You're on mute, Bob.
Yep, no, I just found it. So here's the title of our paper, How Price Regulation is Needed to Advance Market Competition. If you could move to my one slide, the next slide. I thought I got all of my major points in on one slide, but as we were talking just before going live, Mike pointed out that we never really had made the cases why prices are important. So I will pretend there's a bullet up front. Prices are driving healthcare spending right now. Over the last 2 decades, it has been the leading cause of increased spending that results in private insurance markets with increased premiums, decreased take-home pay for workers, et cetera, et cetera. But also, we'd make another point that's sort of consistent with our thesis that we laid out in this paper, is that the focus on prices and high prices is driving hospitals to merge and acquire for purposes of having market leverage and not for purposes primarily of improving quality or improving access or becoming more efficient, but basically to get higher prices to drive their revenues. So for just taking one example, and then I will move to my regular bullets, between 1995 and 2000, commercial insurers were getting about 110% of the Medicare rates, and Medicare is pretty much pegged to the hospital costs. So they were getting about 110% of Medicare. And in most recent studies, that number has increased and increased. In the most recent RAND study from a couple of years ago shows the numbers now approaching 250% of Medicare. It is a major healthcare issue that a lot of health economists and health policy people are focusing on. So now I'm going to pick up is what can we do to address these prices? I think the others like Mike might want to say a little more about the problem. I'm going to talk about our basic thesis in the paper. And these, I have them all on one slide. They relate to each other, so I may jump around a little bit. The basic argument is that price regulation can foster market competition over important aspects of delivery other than prices. If you're regulating prices, you're not relying on market competition over prices or price competition. But point number one, this will happen if it's carried out with an eye to advancing market competition. And I would point to a couple of payment approaches that commercial insurers or government programs are using that may in fact not be pro-market competition. One would be narrow networks. I certainly understand why insurers use narrow networks. It gives them a little leverage over price negotiations, but ultimately it takes away patient choice and is not very pro-consumer anyway. And Bob will be talking more about the problem of fixed hospital budgets, which have gotten attention, but we argue, unless they're done more creatively, are anti-competitive. One reason we did this paper is to reframe the debate so that regulating prices might be viewed as more palatable to what's in general an anti-government US political environment. We basically think that by arguing for price regulation because it promotes competition is a stronger argument than we didn't want to do this, but we're going to have to regulate prices. We understand that it's not competitive, but we got to do it. That's a less powerful message. We want to argue that it is actually pro-competitive, and it's based, in my mind, I sort of got this idea about exploring this topic in reading a book by Tim Wu, who was a law professor at Columbia and now in the White House. Lena Khan, who's now the head of the FTC, and others have pointed out that antitrust policy got off track when Robert Bork and then the Supreme Court defined the purpose of antitrust as to promote consumer welfare as defined by prices. So all the other problems of monopolies and concentration in many markets, not just healthcare, when it gets reduced to prices, sort of misses the point. In the case of healthcare, the consolidation not only raises prices, but it also compromises other important aspects of healthcare. And yet the focus has mostly been just on the prices. So I found some OECD literature as well as literature from the European Union that basically shows that European and other OECD countries have actually evolved to promote more competition by relying on continued yet altered form of price regulation. They actually argue and have reviewed literature that's available that when you regulate prices, you actually can improve, but do improve quality, you improve patient choice, and you create incentives for more efficient healthcare. But as I point out here, and Bob will talk more about it, if you have fixed hospital budgets, the experience in Europe was basically that leads to queuing. You've got your money in the door. You don't actually have to provide services as you would if you were in a competitive market. So they've actually moved away from hospital budgets to reliance on DRGs, which they don't call that volume-based, they call that activity-based. Depends on where you're coming from as to how you label stuff. These countries do not assume, as US economists typically do, that market competition requires price competition. And in fact, we've rarely had price competition in US healthcare. Back in the 70s and 80s, Luft and Robinson defined the term medical arms race, hospitals competing by the newest and fanciest technology to attract patients, and they labeled that non-price competition. So most of the time, with the exception of a brief period when HMOs were flourishing in the mid-90s, we haven't had price competition, and we certainly do not have it now. So make a virtue of necessity and move on to regulation. And the last bullet is that as I've suggested before, is that the focus on prices and pretty much only prices, that the whole purpose of competition has obscured the effects of consolidation, mergers and acquisitions, the development of oligopolies and even monopolies on other crucial aspects of healthcare. For example, the growing domination of powerful health systems over other components of delivery, including health professionals. So that is sort of the theory. To summarize it, we basically think that it's accurate, but also it's a better tactic for trying to engage policymakers in moving towards price regulation than by saying, well, we regret to do this, but we're going to have to do some regulation. Let's be straightforward about it, and let's adopt it and then do it right. And with that, I'm going to turn it over to Bob.
Okay, great. If we could get my first slide up, that'd be great. Just a couple of introductory comments before I go through the two proposed payment systems that we have in the article. One, we tried to look at so-called lower intensity regulatory models that are less complex and would require less extensive regulatory intervention for a variety of reasons. In particular, we thought that those types of models would be less prone to the dangers of regulatory capture and regulatory failure, and then could also be more easily implemented at the state level. We focused at the state level primarily because we think federally there's a difficulty getting major legislation through, given some of the congressional gridlock that we've experienced in recent years, and then focused on hospitals because they provide a sizable proportion of health expenditures, and there's evidence of significant market failure in the hospital market. So the two proposed lower intensity payment systems that we had in the paper were first out-of-network caps. And just to kind of set that up, this is a dynamic that I was first alerted to by a colleague, Jack Keene, who's done a lot of negotiations with hospitals, where hospitals can enhance their negotiating leverage with a health plan by threatening to go out of network and then bill full charges to plan members. And if a hospital retains a substantial proportion of those patients, then the plan can experience, if the hospital goes out of network, both reduced a number of providers in its network and also higher overall plan costs. And that this threat has been used in negotiations by hospitals to increase their in-network fees. And so we theorized that setting out of network caps that could be gradually reduced over time could bolster plan negotiating leverage, shift negotiating leverage back to the plan, and so that they could negotiate lower in-network rates, depending upon where those caps were and how quickly, gradually they were reduced. I'd point to the Medicare Advantage market, where it potentially is an empirical example of this dynamic. There are other studies that have been out recently where states have imposed caps on out-of-network services, and some evidence of a spillover effect on in-network rates. And existing research done by Erin Duffy and her colleagues show that there could be substantial positive impacts on in-network rates over time under a system of declining out-of-network caps. Now, all of this is a bit theoretical. There certainly are caveats. This may not be completely generalizable to a commercial market, the Medicare Advantage experience, but I think it's time to try to test this theory, and that's what we suggested in the paper. It has the advantage of only regulating a small proportion of the market out-of-network services, and then allowing market negotiating dynamics to take place on the vast majority of services in network services. If I could move to the next slide, I'll talk a little bit about our second proposal. It was to regulate at what I refer to as flexible hospital global budget level. There are instances in past history of success with hospital global budgets, most notably the Rochester and Finger Lakes demonstrations in the 1980s. More recently, we've seen Maryland implement and have some success with fixed global budgets. The global budget's been found to improve hospital operating, financial performance and stability, predictability of payment, but at the same time also providing incentives to reduce unnecessary utilization and then constrain overall hospital expenditure growth, because the updates to these budgets are effectively regulated by a regulatory agency. Maryland, when I was at the HSCRC, we implemented fixed global budgets for rural hospitals. We thought that made some sense because the rural hospital cost structure were largely fixed with capital depreciation and standby costs. And so 100% fixed budget we didn't think would be disruptive. But in 2014, after I left the commission, the state moved to a system of fixed global budgets for all hospitals. Now, I should caveat that to say that since that time, they have applied a so-called market shift adjustment mechanism to try to make the system a little more flexible. But notice during the demonstration that there were issues in applying fixed budgets in terms of restricting access to care. We see in Europe under fixed budgets, increase in waiting time for elective procedures. Maryland currently has the highest wait time for emergency room procedures in the nation. There were cases of hospitals trying to close services and also shed patients by not renewing specialist contracts. So the overall conclusion I had is that fixed global budgets were too rigid, and as Bob said, maybe even anti-competitive. So we went back to a system that was pioneered by Hal Cohen and Jack Cook at the HSCRC in the 1990s, which was to pay hospitals on the basis of changes in their variable costs as volumes change. That type of system creates, in essence, the same incentives under fixed budgets to reduce unnecessary utilization, but it covers additional costs when patients are shifted to a hospital by price-sensitive payers. And then at the same time, when volumes decline, that system covers the hospital's fixed costs, removing the resistance of hospitals to systems of managed care and ACOs and other value-based payment mechanisms that intend to reduce unnecessary utilization. The approach that we suggest was proposed to Vermont in 2014. It was more of a regulatory at the aggregate budget level and dispensing with the detailed unit rates and complexity of the current Maryland system. It is more similar to the system that was implemented in Rochester in the 1980s. And I would note that system was administered by an entity that only had 5 or 6 staff people. So it's a much easier administrative burden for a state than a more complex system like Maryland's current system. So those are the two approaches that we suggested. There are other advantages and modifications that could be applied, but I'll stop here and turn it back to Laura, I believe, or I'm not sure who's next, maybe Mike.
Thank you both. Yes, I want to turn to, actually we're going to go to Miriam first and then Mike. So I want to ask both of you to give just your general kind of responses to your reading of the paper, in particular focusing on kind of the theory portion. We will get a chance later on in the discussion to talk through some of the ins and outs of the specific proposals, but really around the theory that competition and regulation can be compatible. And also, if you want to address the question that came up at the very beginning of, why, taking a step back, why do we actually need to do something about prices? Why are prices a problem? You may or may not want to address that. I know Mike had some thoughts on that. So let me turn first to Miriam, and then when you wrap up, you can just hand the virtual mic over to Mike.
Thanks again for the invite, and I'm really delighted to be here because I think that this is a really important paper, and I think it's kind of, I think possibly a watershed in terms of how we think about the issue of competition and regulation. And a lot of my comments they draw on my work with my colleagues, so I just wanted to acknowledge that. So for a long time, we were talking about volume and utilization, and then we started talking about prices in the last 15 years. More recently, we've really started to look at regulatory approaches, and this is evident in the surprise billing debate. And to address your question about the importance of prices, I think that it's plain that there's just been so much opportunism and excessive prices and nonsensical variations. I think that's really one of the reasons why the surprise billing issue became such an issue, was that there was no relationship between the prices that people were being charged and the cost of the service. And that is that's destroyed the credibility in some ways of what is going on in the healthcare sector. And it's illustrated kind of the worst aspects of our system. So in terms of price regulation, I think that other systems are much lower cost, but traditionally what we're focused on more is the universal coverage aspect. When you think about it, all of these countries, their shift to universal coverage was really about figuring out how to pay providers. And over time, they developed more comprehensive ways of regulating prices. They didn't always start out like that. In terms of the competition piece, this is where the article really gets to the sort of myth-busting piece. And in a sense, although many policy experts know about the use of competition in other countries, commonly there's kind of a lot of stereotypes in health policy around what happens in other countries. And the introduction of competition, there has been a robust introduction of competition in many countries, but it has tended to be around provider choice with very limited competition on the insurer end, or to put it another way, a degree of choice, but it's also regulated in terms of the payer side and the purchaser side. I did just want to contrast the experience of two countries that are not in our study, but I know well, and that is New Zealand and Australia. So New Zealand allowed public providers to compete on price. And one of the real issues that emerged in that was the transaction cost issue. And they recognized that this was very difficult to set prices, but it was also really difficult to monitor those contracts. In Australia, there was a very different approach, and it was much more, to use the author's term, a much sort of more heavy-handed approach. But there's a lot of competition still in Australia. There is that system within a system of price regulation, and there's even competition on the financing side with private insurance options. So there's a lot of variations in terms of how competition is done. It takes many forms, but it's all done within that framework of regulated prices and some sense of reality in terms of what's paid for healthcare. One more point is that I think that the role of the government and other healthcare systems, and this is where we're going to need a bit more sort of work. The role of government in terms of being the umpire, not the empire, the umpire of the healthcare sector is important. And what we've seen in states like Massachusetts is that having an institution like the Massachusetts Health Policy Commission, I think is a really important sort of piece of these reforms. Plus, in terms of the issue of antitrust, in some ways, the fact that we've had a really complicated relationship with antitrust, we have sort of not used it enough, and then we've been too restrictive with its use in terms of allowing insurers to work together and negotiate as a group. This is a key element of the systems in other countries, that there is the institutionalization of processes that allow coming together of different actors. And so if you do have a more sort of heavy-handed approach like Australia or most countries, you still need, if you're going to have more than a single payer, you're still going to need a mechanism perhaps where people can come together and negotiate those prices. And that's a really defining feature of those systems with more than one insurer. I think that's all I have. So, Mike.
Yeah, go ahead, Mike, go ahead.
Miriam, thank you. Laura, thank you. Health Affairs, thank you. Bob and Bob, thank you. It is nice to be here to talk about this topic. I'll start with a simple answer as to why is this an issue or why is this a problem. So high prices lead to high spending. High spending leads to a bunch of different activities, many of which are deleterious. Putting people in high deductible plans that discourages access and discourages use of high value care, reducing network access that has a bunch of problems. There's a bunch of reduction in wages that occur when premiums are high, a bunch of other distortions. I should add, although high prices are a problem, I don't want to imply that lower prices are always better, because obviously you could force prices to be zero. You must be concerned, as Bob did, that when you try and lower prices, there's issues with quality, there's issues with access. So we're trying to come up with a balance. The real problem here is when the prices are high because of a bunch of anti-competitive behavior. And I might add, anti-competitive behavior can occur in markets that seem like they're structurally competitive. You can have a lot of hospitals and still have a lot of anti-competitive behavior for a bunch of reasons because of problems in the healthcare sector. And maybe we'll talk more about that going forward. But for now, I want to address, I think, your first question, Laura, which is sort of the sort of idea behind this big picture idea about price regulation and promoting competition. I agree with what Bob Berenson said at the very beginning, that a lot of this paper I view is mostly framing, to reframe the debate. Because some of this ends up being semantic. So let me just make what I think is broadly a semantic point, and then we'll go on to a bunch of questions. Healthcare is multidimensional. There's price, there's quality. Quality itself is multidimensional. Competition can occur along any of those dimensions. And when you limit competition on one dimension, I view it much more as not promoting competition. You're basically redirecting competition. You're limiting one facet in which competition can work, and you're heightening dimensions of competition in other facets. And really what matters is whether you think those other dimensions of competition are better than what would be happening under, say, price competition for a bunch of reasons. So for example, if you push us towards no price regulation, no price competition, you'll potentially have quality competition. That might be a good thing, but you could have competition along, how nice are your lobbies or a whole bunch of other things that would be worse. So you need to just think through what type of competition you think you're going to get. The regulation isn't preventing competition, which I think is a semantic point that the paper is making. It is redirecting competition, and it's doing so in a way that is trying to overcome what I believe are obvious market failures. And to emphasize the obviousness of the market failures, you don't get the degree of within market price variation that we observe, in my opinion, without market failures. You don't see the relationship between hospital mergers and consolidation, both horizontal hospitals merging with hospitals or hospitals buying physicians, and the impact of that on prices without some aspect of market failure. You don't see some of the other billing things that you see going on if information and competition is perfect. So I don't think it's hard to point out that the market, whatever that means broadly, is not functioning very well, and it's functioning in ways that would suggest some role for government to prevent the abuses that might occur the way they would in any antitrust industry type activity. And saying that is not, I am a relatively pro-market economist, but acknowledging that markets don't always work, I think, is an important thing for even pro-market economists to say, and trying to come up with fixes matter. I don't think it's an either or. The reason why we call it the Healthcare Markets and Regulation Lab is we're supportive of markets, but recognize that in some cases they fail and you need regulation, and how they work together is what's important. And what's nice about the Bob and Bob paper is they're trying to find ways to have regulation support aspects of markets. So I'll stop there. I have a few more comments, but hopefully they will come up in the questioning.
So now we'll have some discussion amongst you all. And there's have been some questions that have come in. I've seen those in the Q&A. So there's a few questions around kind of the specifics of the proposal. And also I think Mike and Miriam may have some comments about the specifics of the proposals that Bob put forward. So I want to give you a chance to do that. And then we will get to, there are questions on some other topics, but I think we should first take a minute to kind of dive into, because there are quite a few questions about, how would this work? So I want to actually, I think I'm going to come back to both Mike and Miriam now, and then we'll go to the questions on this topic. But are there any issues related to the specific proposals that Bob put forward that you want to particularly comment on, that you see as being very promising or particularly problematic, or that you in whatever other way want to make sure that you emphasize? So that could be either the out-of-network pricing or the flexible hospital budget. Mike, you want to go ahead?
If Miriam, if you want to go ahead, please. Otherwise, so again, I'll try and be brief. So first, I want to acknowledge that the paper raises things, but it does so a little bit in a paradigm of experimentation. So I think there's a state level notion that states can do different things and that there's not necessarily a clear answer. So I'll talk briefly about each. In terms of the out-of-network policy approach, I do think there's a lot to speak for some merits of doing that. I think some of the core questions are how aggressive you want to be, recognizing what I said earlier, that lower prices aren't always better. So how aggressive do you want the caps to be? I do think it's important not to assume that if you lower prices, however you do it, that you're necessarily going to get the exact same thing. And obviously it matters how much you lower them. And so I tend to support things that start weak and then you see what happens and you ramp up in varying ways. The out-of-network price cap has that feature. My concern with the out-of-network price cap is if the hospitals can simply say, we will not serve you if you're out of network. Imagine that you're MGH, to pick a hospital here, and they're negotiating and you say to the insurers, fine, we'll go out of network and we will go out of network with the out-of-network cap, but we're not going to serve you. For whatever reason, we're going to put you at the end of the line. Then my sense is employers would not be so keen to have them out of network and you would miss certain pricing problems. So there's a question about how well the out-of-network cap will translate to in-network caps, although it makes sense to me that you might want to start with the more timid out-of-network cap, maybe even timid caps on the out-of-network prices, and begin to ease your way into what's going on. It is non-trivial to make it work, and you have to be careful. The other thing I would say, and this might be even more relevant to the global budgeting discussion, is one of the big debates. I haven't read all the questions on the chat, but people tend to differ based on how well they think the government will actually work. If you think the government can work well, you tend to like some of these regulatory approaches, and you think the government is inevitably going to do a bad job, then you tend not to like these government approaches. So my concern with the hospital budgeting model, and again, Maryland is making it work in a range of ways, is it strikes me that doing this sector by sector, hospitals and physicians, creates a bunch of problems. You could think of other approaches where you might have these patient-based models where patients are assigned to a group and then there's a budget that's flowing by patients, not by sector. Again, I'm not going to argue one is necessarily better than the other. I think there is some room for experimentation. I prefer patient-centered thinking about things as opposed to hospital-based centered thinking of things because of how the services can move out across the hospitals, but out of the hospital in a bunch of other ways. But that's my take on these, that they're all worth exploring. Different states will have different appetites, and the implementation will matter, and you shouldn't expect you're going to get one spot on right. Maryland's been doing this. Bob Murray will tell you, Maryland's been doing this for decades, and they change and they try and fix as they go along. And I think all of these will have that flavor. And at some point, you just have to decide how much are you willing, what approaches do you want to deal with the market failures? My general view is that I'm supportive of antitrust. I believe transparency can help at the margins, but I don't think any of those things will get us where we might want to get to in the time period that we have to get there. So I think there is some role for regulation to deal with the worst abuses. And I'll read the chat to see which ones people like.
I have a feeling Bob will probably want to respond to that. So let me go to you for those.
Well, maybe respond to Mike's 2 points on the two models that we proposed. One, yeah, in any sort of regulatory structure, there are going to be issues that aren't completely anticipated. And so that calls for some gradual approach to these processes. With out-of-network caps, as Mike indicated, you have the ability to moderate the caps or lower the caps over time, and then states can monitor the impacts on hospital finances, financial profitability, also on quality of care and access, those sorts of things. So I intentionally structured this so that it would be a gradual lowering of caps in a particular state, and maybe have caps vary regionally by state. I'm in California, and you have much higher prices in Northern California than Southern California. So it argues for some degree of nuance in terms of how some of these things are implemented, and also monitoring the effects and then readjusting over time if there are negative effects. Now, I think out-of-network caps overall will reduce hospital negotiating leverage. It may not be absolutely effective in every single case. If you have a hospital with tremendous market power or a must-have hospital, it may not have an impact on that negotiating structure. Now, if hospitals start to refuse to provide care to individuals, that may be a separate legal regulatory issue that should be addressed in those forums. But I don't doubt that hospitals will respond to these types of limits, perhaps in less desirable ways. With regard to global budgets, I agree with Mike that it is a sector-specific payment model. You are going to see responses if you're just regulating hospital budgets only, as we've seen in Maryland, where there is a shift from the regulated sector to the unregulated sector. But that argues, again, for some degree of modification of the proposal over time. Global budgets could be expanded to include hospital-based physicians, hospital-employed physicians, long-term care, home health. You could also envision a system where a global budget was created on the basis of the ownership of services, or health system ownership of services. So putting more services under the global budget cap. Now, as you start to do that, of course, these systems become more complicated, and that creates a whole series of other issues. That's why I intentionally wanted to start smaller and apply gradual changes to these models to try to see if they could work. And certainly, I think they would be effective eventually within the sector that they were applied to.
I'll just make two quick comments on Mike's initial points. One is I'll completely accept redirecting competition. That's actually probably more precise than how we did it. We called it advancing competition. Redirecting is fine with me. The point I would make there is that this idea will be denounced not as redirecting competition, but as substituting government intrusion for competition, in many cases with a stated or implicit assumption that the market is now working. But in terms of precision, I'm all for what Mike suggested. It's about redirecting competition. On the point of there's always a danger of being too aggressive with prices and you drive prices down. And I think there's probably evidence that some state Medicaid programs have driven prices too low. I think that's possible. But the political economy for commercially insured patients, employer-sponsored insurance is such that I don't think that's a real danger of driving prices too low. I mean, in a couple of states that have actually tried to set caps on government employees, like North Carolina, and is a good example. The hospitals did say we're not going to play with a 200% of Medicare cap. And the state had to retreat on that notion. So I hope we actually get to a problem of worrying about driving the prices too low. I would be more than happy to just start high and then see where we go from there.
And to the point of Mike's maybe reframing our argument, redirecting competition, I agree that's perhaps a better way of characterizing it. Although I will point to examples, as in Maryland, where the rate setting system during the 80s and 90s actually had impacts on promoting price competition amongst insurers, in that the hospital rate setting system in Maryland kind of leveled the playing field for insurers and allowed smaller health plans, managed care plans. This is the case also in Massachusetts to an extent, to enter the market. And so I think it's more of a direct evidence of price regulation in the hospital sector, promoting price rate competition in the insurance sector. So I think it can have both a redirective type of impact, but also a more direct impact in competitive dynamics in the insurance sector, for instance.
I see Miriam nodding her head. Yeah, go ahead, please.
Yeah, I think one of the really striking things that I read in the article was about the notion that if you standardize prices, you actually allow the proliferation or the entry of new competitors on the payer side. I think that this comes back to this issue of transaction costs, and we have too many transaction costs in the system, and that by sort of streamlining the process could be really, really important in terms of making the whole system work better. And I think that's one of the takeaways of other systems is it's not sort of whether it's government doing it or who does it. It's really about having a system that everybody follows. But I think all of you have raised important points about how do you sort of keep people in that system, because in the US, I think the biggest challenge is how do you keep people participating when everybody, there's a tendency or a threat that everybody's going to say, I'm taking my bat and I'm going home. I mean, that is one of the problems. And so you have to figure out in any sort of system like this, how do you incentivize, and it's payment rates, but it's also other ways to incentivize providers, both physicians and hospitals, to stay in the system. And that's kind of a question, I guess, I have to Bob and Bob.
Do you want to take that?
I mean, it's money, obviously, but it's also, can you incentivize them in other ways through regulatory relaxation on other things, malpractice issues? I don't know. There's other levers that governments can do or use to encourage participation in the system.
Yeah, I think that's a difficult question. I do think there are other advantages to regulatory systems along the lines of what you said about the standardization of payment that can, in the end, be more advantageous for providers. But for instance, global budgets provide some high degree of financial stability for hospitals because it provides them with a more stable payment flow. So that's one aspect of how government regulation can perhaps be more attractive to providers. Certainly, global budgets could be very attractive to rural hospitals or distressed hospitals in urban areas. So there's that type of effect. There's also the ability of payment systems to make the payment not only standardized, but also payment structures more equitable. The Maryland system has many advantages that other states probably couldn't experience, but Maryland does have a very equitable system. And with certain payment systems over time, like global budgets, you could actually adjust payments of different payers to narrow these huge payment differentials that exist between public payers and private payers. The theory there is that with global budgets, as you generate savings by constraining rates of growth and incentivizing hospitals to look at improving their management of care and providing less low value care and discretionary services, that those savings could be used to lower commercial rates and raise public rates so that you would narrow those differentials between those two sectors, which is a real problem that we've gotten ourselves into. So there are structures within regulation that can, a regulatory approach that could make the overall system more attractive to providers, provide additional stability, and also work to improve things like equity and financial stability for providers and hospitals.
I would just make a quick point that one of the theoretical concerns about standardizing prices is that it may suppress or limit innovation in payment, that some payers might have come up with a better mousetrap. I believe that in Maryland, they did have a sort of a waiver process for insurers who actually did have innovative payment models or wanted to test innovative payment models. The general point I'd make is that Medicare seems to be the innovator in payment. For the most part, private payers are emulating and adapting, or in some cases doing partway Medicare payment models. So in reality, I think it hasn't borne out that having standardized payments interferes with innovation, but it's at least a theoretical concern. And I think it needs to be accommodated. In the paper, we do talk about regulatory capture and regulatory failure. And there's no question that those are dangers, and it is a reason why we prefer to start with regulation light. But the membership, the nature of the body that regulates, is it an independent commission? Is it a part of state government, et cetera? The membership on that, if it's a commission, who gets to sit on it, are all very important operational questions that have to be dealt with. One final comment on negotiation. I know that Germany in particular and some other countries actually do have multi-payer and multi-provider negotiations. In the US, I'm not sure that would work so well because of at least on the physician side, because of the domination of specialty interests as we see manifested in the RUC, which I know Miriam knows plenty about. So I think there are other ways to do it, but negotiation, I think where it can work because of the culture of the society and the makeup of the decision makers, is obviously a good way to go, but I don't think we need to necessarily go that route. But it's worth, I mean, there's a lot of operational details as we get into actually pursuing this kind of a more regulatory approach to pricing. We have a long way to go to even get to the starting line.
I don't know, Miriam, if you had any response to that. If not, I've got another question.
Can I jump in at some point, Laura?
Yeah. Why don't we go Miriam and then Mike?
Okay.
Really important, this issue of how do you sort of have negotiations, how do you set that process up? And that's a question that would depend on who is setting prices and how. And in a sense, in other countries, it's sort of very consensus-based in multi-payer systems and more top-down in single-payer systems. I agree with Bob that this is a false idea that innovation is somehow stifled in such a system. But au contraire, that in the case of the private insurance market at the state level, you've always seen private insurers follow the state mandates, mandated benefits, because it's just easier to have one kind of method of doing things. And this comes back to the standardization argument that the principal benefit of this would be to streamline our health system. And I think that's an equally important goal.
Thank you.
So,
Mike.
yeah, let me just say a few things. The first one is, one thing that's nice about the out-of-network cap idea is you allow as much innovation as you want in network in a whole range of ways. And I actually think that matters. And I would say that while it is true that Medicare might be out in front now on payment reform in some ways, a lot of the things, ACOs, for example, I think grew out of some experience here in Massachusetts with the Blue Cross Blue Shield, and some other things that were going on in the commercial sector. I think the same is true potentially in episodes. So we would have to debate who's leading and what drives them to lead. I think that's a little bit besides the point. I think if you do the out-of-network cap issue, you allow all that other innovation. That's point one. Point two is a lot of this underlying discussion, which is somewhat unique in the US, has to do with taxes. And I think it's difficult to separate out our health policy debate from our debate about broad fiscal policy. So again, I looked to Bob Murray to make a comment on this. The reason why Maryland works in part, I'll defer to Bob to say how much in part, is because they get a large subsidy from Medicare, essentially tax funding, to enable you to make this equalization of payment rates. And so if you wanted all payer rates to be the same, understand that would almost inevitably entail higher public rates and lower commercial rates. And that has ramifications for taxes. That is a broader topic than I particularly want to get into. I will, for lack of better judgment, say one thing about Medicare prices. So first, before I do, let me emphasize this. I am speaking as Michael. I am not speaking as MedPAC chair. And in case you were just got in a soda, I'm speaking as Michael. I am not speaking as MedPAC chair. I think it becomes challenging to run a Medicare pricing system when the decisions that are being made by Medicare ripple through the system writ large. You run the risk of a whole bunch of dysfunction that goes on in Medicare, of which there is a lot, and a whole bunch of other policy concerns related to taxation moving through the healthcare system writ large. So the sequester, for example, would apply to everybody depending on how you did it. How you deal with wage reclassifications of hospitals would deal with everybody. How you deal with site neutral payments would deal with everybody. There is a slew of core problems in how we run Medicare that I guess I will pull my punches on in what I think about them that are very challenging. And if you were to impose Medicare prices or Medicare price limits on everything, it becomes problematic. It works really well when one relatively small state wants to benchmark off of Medicare. It becomes harder if the entire system benchmarks off Medicare, because I believe there will then be feedback effects on the actual Medicare program. So I think one needs to be really careful about how one thinks about that. I am, by and large, you might imagine, a fan of Medicare. I think Medicare has done wonderful things for beneficiaries. I think the Medicare price setting process and other processes in Medicare are far from perfect, but I think the commercial sector is far from perfect. So I often say, this is about my kids. I love my kids. My kids aren't perfect. I like Medicare. Medicare is not perfect. I love the markets. The markets aren't perfect. We are choosing between imperfect options. And it's important to try and do the best in each setting, but I am a little wary of simply saying we should have all payers pay the same amount and not understand that the underlying shift from financing our care through the commercial sector versus financing it through taxes is a benign or unimportant shift. It's a very big deal, and in my opinion, and I'll let Bob or Miriam, for that matter, comment on that point.
Let's take one response to that. And then I want to shift gears a little bit, and I'm going to ask another question, and then we will get to the audience questions.
Just very quickly on Mike's point about Maryland. Maryland has been very advantaged by the Medicare waiver that it negotiated, which effectively has Medicare and Medicaid pay much higher amounts in the state to hospitals than they do nationally. That's not something that could be duplicated. And I'm not advocating changing tax policy to raise Medicare and Medicaid prices. Let me just say the positive aspect of that for Maryland is it galvanized support for the rate setting system from everyone, hospitals, payers, the state, because they don't want to lose that subsidy. So that's a situation that's specific to Maryland. It's unique to Maryland. I was advocating hospital global budgets. I wasn't advocating equalizing payment rates. I was advocating starting out with existing payment levels and then moving forward by constraining rates of growth for all payers, with the possibility of over time gradually narrowing those payment differentials. But so to be clear, what my approach or my recommendation is, start out with the current system, the current payment differentials, current hospital historical budgets, and then transition into a system that was more rational, that had more constraint on payment growth over time, and not raise taxes. to bolster public payments, because there's an argument that public payments, Medicare payments, are adequate for hospitals. Maybe not because because hospitals are relatively inefficient, but we don't want to raise Medicare payments unnecessarily.
All right, thank you. We could continue with this, but I would like to shift gears a little bit. I want to ask a question about the politics, getting away from the specifics of these approaches. What do any or all of you think are the political prospects for states to implement something like what Bob proposed, or what Mike and his colleagues have proposed, or other kinds of methods to address prices? Are there any specific states that you think are likely go-tos for this? Who needs to do what? How might we see this get started? I'll take whoever wants to.
Well,
And that was
Bob and I flipped a coin and he won, so he's gonna go.
yeah, well, I might take a crack at this. I've had some interactions with various states. My observations are the states that have previously proposed these total cost of care benchmark targets are probably the ones that are thinking about rate regulatory structures more seriously. I think it's a process where you want to control overall spending. You have these benchmark approaches which seem relatively benign, but over time you realize that it's technically very difficult to implement or enforce these types of global regulatory structures. And so far, although Massachusetts made a lot of progress in collecting data and analyzing cost drivers, and it's been a very productive project from that standpoint, I think eventually you get to the conclusion that this is not something that can be enforced at the individual provider level. And so we need to think about other approaches. So you get states like Massachusetts, Washington State, Oregon, Delaware, Rhode Island, Connecticut, that have all gone down the path of total cost of care benchmarks. I know California is thinking about that, but when they realize the difficulty in enforcing and controlling rates of growth under that strategy, they become more receptive to things like out-of-network caps, which is, again, I would say was more regulatory light, or hospital global budgets. Rhode Island has expressed some interest in global budgets. New Mexico also has expressed interest. I know Vermont before was very interested in global budgets. So I think they have to go through that evolution of thought process and discussions with stakeholders, and eventually states that have led that type of approach are getting to the stage where they think, no, we've got to apply more regulatory constraints authorized by legislation to address the pricing issue. That's my observation thus far.
Does anyone else want to address that?
Yeah, I think New Mexico is a really interesting case, and that a lot of these state efforts, as they multiply, they do change the conversation. I think in previous decades or years, it was, Maryland's doing something, but that was sort of an isolated case, where it starts to gain a lot more momentum when there's more than a handful. So I think that changes the political debate. I think that it's really helpful to think about the states actually starting these efforts, because I do think that it gets away from this heavy-handed government argument that is maybe more associated or more, there's more of a focal point at the federal level. So I think that the state going in that direction is a pretty good one on balance, because it's achievable. States can choose to do that.
Great. Well, let's try to take a couple questions. There's been so many great questions that have come in. Sarah, do you want to? I think, speaking of states, we've got someone from Massachusetts that asked a question. You want to go to that one?
Yes. Stuart Altman asked, what do all of you think about having states start their path toward regulating prices by first establishing spending benchmarks with spending controls under the benchmarks? As you all know, that is what we did in Massachusetts and are now being implemented in several other states.
Well, again, I would go back to, I haven't talked to all the states that have done this, but I think when you have these types of limits at an aggregate level and then try to hold individual providers to those limits, you get into a myriad of technical issues. And how do you measure an individual provider's performance over time? I mean, are you assigning patients to to a provider and then look at what the rate of growth is on a PM basis? How do you actually enforce it from a regulatory standpoint? I mean, do you apply fines? What are the political implications of doing that? The general sense I get is that states that are going down this path of doing total cost of care benchmarks is that they're realizing that it's technically very difficult to operate and implement, and then extraordinarily difficult to enforce at the individual provider level. You have to make all sorts of adjustments for severity differences, for different patient populations. And so I think it's a large undertaking that states perhaps didn't anticipate, and that's why I think eventually they'll gravitate to more directed regulatory structures, like either out-of-network caps or global budgets, or perhaps limitations on rate updates, which is another regulatory model I think Mike discussed in his paper.
Great, thank you. And thanks for the question. Maybe should we move to another question? Sarah, you got something?
Yeah. So Bob Liebenluft asks, under the current system, hospitals compete with each other for patients based on prices and quality, including access, recognizing, of course, that there are real market failures in that competition. But if prices are regulated, why is it clear that the result would be more or better competition based on quality? Isn't there a risk of a return of the medical arms race, or conversely, little investment in quality, unless there is far-reaching, complex, and technical regulatory oversight, which raises all of the concerns as to whether that can be done well?
Well, I'll take a shot at a response. For the most part, insured people, with the exception of those who have just monstrous high deductibles, don't really respond to the prices that hospitals set. I mean, obviously uninsured people do. And I don't think the evidence around high deductibles has shown consumers are very good at discriminating between needed services and unneeded services. So I don't think hospitals compete on price right now. They vaguely compete on quality, although we haven't been able to really measure quality in such a way that consumers get much guidance. I think to a large extent it remains word of mouth views about where to go. People like to go to their local hospital. So I guess I'm not quite sure of the premise of Bob's question. And I guess I'd make one other point. There is an argument, and we actually address it briefly in our paper, that price competition, if it was true competition, allows hospitals to distinguish themselves by having higher quality. They can charge more because they have higher quality, and that gives them an incentive to keep doing it. But looking at the actual hospital finances, and I co-authored a paper with Nancy Kane from Harvard and others, which we published a few months ago in a technical journal. I'd make this point, is that most, but certainly not all, but most health systems have far more wealth in the form of cash and investments, or even more, better measures, actually days of cash on hand, than they need. If quality was going to distinguish them to attract patients, they have more than enough. Just to give you an example from that paper, we had a sample of 50 hospital systems, from individual small hospitals to the largest in the country, which was Ascension with 111 hospitals. And we divided them into sort of size categories: for-profit, non-for-profit, et cetera. The 9 systems that we labeled as large non-for-profit health systems, Now, understand this is finances at the system level, not at the individual hospital level, had as cash and investments, mostly in marketable securities of between $5 and $19 billion. That's a B, not an M, $1 billion sitting in reserves. Some of them had as much as approaching 2.5 years of cash on hand, which is far above what the rating agencies would consider adequate. And if they wanted to distinguish themselves on quality, they could be doing that right now. And yet the literature doesn't show that. Well, basically, it's not a robust literature. Marty Gaynor and others have sort of helped generate it, but it does not look like market consolidation, raising prices, having more assets produces higher quality. If anything, lack of competition in healthcare markets compromises quality. So I'm not sure that I directly answered Bob's point, but I think it's sort of a theoretical but not empirically demonstrated theory that hospitals and health systems would compete on quality. They compete on arms race and amenities and things like that, in my view. And we could at least deal with prices, and then, as we argue in the paper, redirect attention to these harder to measure areas like quality, like patient choice, like responsiveness of the systems. And that's part of our argument.
If I could just say quickly, Laura, if I understand the proposal, it's about capping, for example, out of network prices. And you can do that. The risk that Bob asked about is indeed a risk, but you can do it through a relatively timid out of network cap and ease into where you're going as you monitor, as opposed to pick a cap that is very low, that has the potential impact of being very strong, and that risk could be greater. All of this is seeing a problem and deciding how aggressive you want to be to ease into a solution. And that is as much about the politics and the process and how many bites of the apple you have, as opposed to where you think the end state is.
Let's take another question.
Great. David Hawkins asks, do any of you see ACOs as a mechanism for controlling price through competition? What are the limitations and imperfections of this approach?
Let me just tag on to that. If everybody is paid under a more something that looks more like capitation, something that is more of an alternate payment mechanism, does the need for these kind of approaches diminish, go away? Should we be pushing on that?
I'm not sure if I should answer, but I will say, I don't think we're close to a world of like universal ACOs for a whole bunch of reasons. That's just not what's going to be in the cards. Although I do think in some places, and again, I'd like Bob's thoughts on this, Maryland is moving increasingly towards a population-based way of allocating things to prevent the squishiness outside of where the hospitals are. You're bringing in more physicians, doing more attribution of patients and stuff like that. It's not 100% clear to me all the time what actually an ACO is. I do think ACO models, particularly in Medicare, are an important component of cost control. I don't see them now as functioning as really promoting competition amongst all the different providers we're talking about there. I view it as a different mechanism to control spending that's somewhat separate from price. It does give you, for example, in a place like Massachusetts, the potential to really see what the total cost of care is on a population level and decide what to regulate, as opposed to trying to figure out which providers to go after when the care is being split across a bunch of them. But there's a ton of other problems with attribution, risk adjustment, and a few other things that Bob mentioned. So I think we're a ways away from building a whole nationwide system on ACOs to solve this problem.
And to Laura's point, I would just say, I think it's a mistake to think that changing the payment method addresses market power. You can pay a system per member per month, per person per month, per beneficiary per month, however you wanted to define it, based on whether you're in commercial insurance or Medicare or something. And that entity, if it has market power, can get a high PMPM. And yes, they will have different incentives, but nothing is going to prevent them from using their market power to drive a high rate. So I think I have seen people write that if we just did more value-based payment, like a global capitation, or I mean, ACOs don't go that far. I'm actually attracted to global capitation if we could get risk adjustment right, which remains a problem. But that's still not going to mitigate or address the issue of a system that is an oligopoly or a must-have in any insurer's network, from driving high prices for the privilege of having that capitation. And so then we can get back to things like out-of-network caps and things like that.
But it is a little easier to get your head around total cost of care type numbers if that's how the market power is being manifest than it is when folks are changing the underlying codes, moving you to different sites, and doing a bunch of other things in the fee-for-service system. It's very hard to tie back to what you really care about, which might be overall spending. And there's other advantages related to like volume incentives, maybe. Anyway, you probably want to go into
I
another
agree with
question.
that completely, but I would just reemphasize that after 20 years, we still can't get risk adjustment right for Medicare Advantage plans. And so this is one in which the operational challenges stands in the way of what is theoretically quite desirable.
Yeah, we need another half an hour, Laura.
Just a point about ACOs. I think one of the reasons why ACOs haven't been quite as successful as what was hoped for is that hospitals, their cost structures are antithetical to the priorities of ACOs, which are to manage care and reduce utilization. And hospital cost structures are 50% fixed, 50% variable, and volume reductions result in losses for hospitals. So that's part of the reason why I advocated this flexible global budget approach, which is that it paid hospitals for their variable costs and supported their fixed costs when volumes decline. It would more align the incentives of hospitals with ACOs and maybe help the system move more in that direction. Now, there are other reasons why I think ACOs haven't been successful, but there are models, which I am not that expert in, that are more population-based, PMPM-based models like Kaiser, which is a closed system that has had some success in controlling both utilization and also cost growth, but also models that have been implemented internationally, like in Israel, where they have 4 dominant managed care companies that have created more of a population-based payment structure, which is regulated, that try to do all the things that ACOs aspire to do. So I don't know where that is in the evolution of payment and policy that changes over time, but that may be kind of an end game that states in the United States could shoot for eventually. But you got to start someplace. That's why I like Mike's suggestion. Let's start small. Let's start without a network caps, and then see how that works, and potentially more global payment regulation like global budgets.
Let's see. We're almost out of time here. I think maybe we'll try to take one more question, at least one, and see. Maybe we might be able to fit in 2, but let's go for one more here, Sarah.
All right. Renee Sai asks, could you explain in more detail about how hospitals can hold health plans hostage by threatening contract termination? For example, if a hospital decides to charge $50,000 for a COVID test and is out of network, what are plans required to pay? 100% of charges or some percent of the usual customary rate?
I think it varies from market to market. In the article, we provided kind of a simple example of the dynamic that takes place. If a hospital can retain 30% of a plan's patients and they're charging 500% of Medicare, well, you can have a situation where the plan now is paying more for that same patient population because they have to pay those inflated charges for the patients that are retained by the hospital, but also they have to redirect other patients to other facilities. And there may not be sufficient capacity, and there may be negotiations that go on with those hospitals. So the end result is, in many cases, it results in the hospital or the plan paying more for the patients that used to go to that facility. And then the plan is saddled with going back to their accounts and say, oh, my hard bargaining skills has resulted in a narrower network and higher plan costs, total plan costs. And that's not a situation that payers want to be in. So in most cases, they acquiesce to this threat that I just mentioned. And it goes on very, very frequently, and even can be exercised by a single hospital. It doesn't have to be a health system that has multiple hospitals and market power in a given area for other reasons.
Right, well, I'm going to throw out one last question. This for health affairs and for the many health services researchers that are on the webinar today. And this is for any of you. Assuming that one is on board with the idea that it would be beneficial for some state somewhere to go forward with approaching this kind of regulation of prices, what's the burning question that you would like to see addressed by researchers that would help states kind of shape their decisions in this area? What do we need to know that we don't already know? I stumped you.
We obviously need to know the price quality relationship. And I would say that's not going to be unique. You're going to get a different impact when you're cutting down the very, very top level of prices and when you're really, cutting hospitals that might be at the bottom level. We need to know about the relationships between out-of-network and in-network prices. How will that competition play out? That's hard to do without having that particular experiment. And I think we really need to know a lot more about the sort of efficient production, what the production function of care actually looks like. What is an efficient price in a whole range of ways? We talk a lot about, pricing for an efficient provider. We don't really observe that very well. So I think there's a lot of things in those areas. I guess if I had to pick one that's the easiest to study would be to study sort of the underlying production function of healthcare, but maybe that's just my interests.
Just on that point, I would call out the work that MedPAC has done. Jeff Stensland, in particular, the analysis that you do every year, looking at hospitals that have high quality outcomes, a cohort that are under financial pressure, and what their cost structures look like. They're lower, they're more efficient. So I agree with you, Mike. I think more work needs to be done in that area to demonstrate that it is feasible for hospitals to operate more efficiently. And there are instances, real life examples that have been called out, like the work that Jeff has done, to demonstrate that hospitals can operate more efficiently. And if there are price constraints that are applied, based on my experience in Maryland, hospitals will respond. They will look to try to improve their operating efficiency, lower costs, so they can maintain adequate profitability and also hopefully provide adequate quality.
Jeff's work is excellent. We need another half an hour.
I just want to say one more thing, which is, yes, more research, but I think it's also time to get to the drawing board more than, do more studies, with the exception maybe of, how this surprise billing regulation is going to play out, and also watching from the sidelines how the political aspects of that are going to play out, given, legal action on the part of providers against the regulation. There's just a lot of dimensions that are coming out of that will be instructive, I think.
Well, if you will all indulge me for 1 or 2 minutes, I've got some wrap up stuff here. First, I want to say to thank you all, our panelists. It's been really wonderful having you, Bob and Miriam and Mike. Appreciate you taking the time to talk with us. Thank you to our audience. We had a great, strong audience today. Many of you have hung on and you're still here with us. If you like this Lunch and Learn, I would ask that you visit healthaffairs.org. Where you can sign up for other upcoming events, join our email list, hear about events as soon as they are announced. We also have a podcast you may find interesting that you would like to listen to, a Health Podacy, where our editor-in-chief, Alan Weil, interviews leading researchers in health policy. I also just got the news about 2 minutes ago that we are going to be, at some point in the next couple of days, we'll be posting a recording of this webinar. So we will make sure that everybody gets that information, and we would, encourage you to share that with other folks that you think might find it interesting. I wanted to call your attention in particular to one upcoming event that we have on the slide there. As you see, it's a policy spotlight on February 3rd from 3 to 4 Eastern. It's a one-on-one discussion with Mandy Cohen, who is the former North Carolina Secretary of the Department of Health and Human Services, and is now the Chief Operating Officer and Chief of Staff at CMS. And then Mandy will be interviewed by Joanne Keenan, who is the Commonwealth Fund Journalist in Residence at Johns Hopkins. So we hope that you will join us for that one. You can register for that and for any other events that Health Affairs has. Again, I encourage you to go to healthaffairs.org. And finally, I want to say thank you again to the panelists. A lot of prep went into this, to the authors for a wonderful article, for prompting this this event. And I want to thank also the behind the scenes team at Health Affairs, in particular Debbie Boylan, who is our events manager, and Sarah Kolk, who you've met here today. And with that, I want to wish everyone a lovely day, and we are adjourned. Thank you very much.